For the next session, it will be my privilege to invite our respected chairpersons, senior consultant physicians, Dr. Anup Chhabra, Dr. Utsav Sahu, and Dr. Dayanand.
Good morning everyone. For the start of session, I invite first speaker, Dr. Atul, to please come on the dais.
So Dr. Atul would be speaking on the topic of mitochondrial modulation, bridging the gap between good glycemic control and the optimal diabetic care.
So good morning everyone. In next 20 minutes or so, I'll be talking about a concept which is predominantly a research concept as of now. So we are still trying to get this concept into our clinics. We always have been wondering, if you think about UKPDS, you think about the two arms, the one arm in which intensive control was achieved and in another arm where intensive control was not achieved. Even in the arm where intensive control was achieved, the complication rate was not zero. So that means there is something that we are not understanding about diabetes that is happening where we are lacking. Our patients are still well controlled, but one fine day a patient walks in our clinic and says that he is having problem in his feet, or he went to an ophthalmologist and he told him that he is having retinopathy. So definitely complications, we see complications daily, and we all wonder why is this happening so. So this is something we can think about, this is something to think about regarding this. Talking about diabetes, we know that it is a prevalent disorder and the prevalence is as high as around 11%. If we look at the current estimates, around 77 million people with diabetes are living in our country, and if we talk about total numbers, we are second only to China as far as number of patients living with diabetes is concerned. But our problem is, I'm not able to show. Yeah, our problem is this high incidence of diabetes in the young. And why is it important? Why should we talk about diabetes in young? Because it is the same type 2 diabetes. Actually, it is not. If we talk about type 2 diabetes in young, the young bear the burden of disease much more than the people who develop diabetes later in the course of their disease. So, if we look at the Indian phenotypes, there have been now data, and some of the data has been generated from my parent institute, All India Institute, and they have shown that people who develop type 2 diabetes at a younger age have a higher chances of both micro and macrovascular complications. And not only the prevalence is high, but the age of development of these complications is also earlier as compared to the elderly population. This is a very landmark study, the Today's Study Group, if you remember it. So, just for our listeners, I'll talk about this trial. So, this was the largest therapeutic trial involving around 500 adolescents. So, in this study, the group was divided into 3 groups. One group received metformin, the other group received metformin and rosiglitazone, and the last group was metformin and lifestyle modifications. They studied this group from 2004 to 2011, and they tried to look into the glycemic control. After 2011, these patients were followed up for next 9 years till 2020. And then they tried to look into the number of complications. And you can see, this is what we see in our OPDs also. This is the number of patients who had well controlled diabetes at the diagnosis, and by year 15, only around 19% had an A1C of less than 6.5. And we always wonder that either we are not doing good job, but this is same across the world, that the glycemic control remains so as the disease progresses. But the problem is this, if you look at the complications, 61% of these patients had developed at least one complication. So these are very young people. The mean age at the last follow-up, that is at 2020, the mean age was around 26 years only, and around 68% of these patients had hypertension, around 55% had kidney disease. At 26 years, you are developing kidney disease. This is the problem with diabetes in young. Dyslipidemia again 52% and neuropathy around 33%. And if we talk about any complication, around 80% of the patients had some sort of complication. And more than 3 complications, but as the years in diabetes progresses, the number of patients who had all the 3 complications also increased progressively. So this is what the problem is with early onset of diabetes. The Asian Indian phenotype, I believe you must have met Dr. Yagnik here, and he was the one who taught us about this enigma, and he'll be delivering a lecture on vitamin B12 today. So we are ethnically more susceptible to type 2 diabetes. The age of onset in our population is lower. We have a lesser threshold for development of diabetes as far as BMI is concerned. That means at lower BMI we are developing diabetes. We have higher serum insulin levels. We have dyslipidemia, which is atherosclerotic in nature. Our triglycerides are increased. Our HDL cholesterol is reduced. Abdominal obesity, you can see the classic abdominal belly fat in Indians. Increased inflammatory markers. Birth weight, we have lower birth weights, and then obesity becomes more prevalent as the years passes by. And we also have lower levels of adiponectin, which is responsible for development of diabetes because of lesser insulin sensitivity. So how we can cut the risk? Now we need to understand what's extra. We always have been talking about the pathogenesis of diabetes. Earlier we used to talk about the triumvirate process, where we used to talk just about liver producing increased amount of glucose, reduced uptake by the muscle, and impaired insulin secretion. And then we started understanding that it is not just these 3 organs that are in problem, but it is basically these 8 things that are not doing their functions properly, which leads to development of diabetes. There is a reduced incretin effect. There is higher lipolysis, that is, there are changes in fat cells, which leads to changes in adipokines, which leads to insulin resistance. Renal problems. So if you look at your diabetic patients and if you are following their reports, even when their blood sugars are say 230, 240, their urine glucose is absent. This is because increased amount of glucose absorption from the renal cells. Muscles, there is reduced uptake. There is also neurotransmitter dysfunction, which leads to changes in insulin secretion, and liver, islet cell pancreas, and reduced insulin secretion. We have been talking about these pathophysiologies. But despite understanding all this, still there are certain problems we are facing, so that because of that we are not able to adequately control our patient, and which is associated with complications in our patients. And probably mitochondrial dysfunction is one of those aspects that we don't understand. So if we talk about development of complications, we all know that diabetes is associated with visceral obesity, which is a state of chronic inflammation, and this leads to increased aldosterone and glucocorticoid production because of increased activity of the RAS-aldosterone pathway, and this leads to macrophage activation, and this further increases inflammation as well as atherosclerosis. Further, because of chronic inflammation, there is disbalance in secretion of adipokines, because of which pro-atherosclerotic cytokines are released in larger quantities as compared to anti-inflammatory adipokines, and this leads to atherosclerosis. But how mitochondrial dysfunction trigger this? Mitochondrial dysfunction leads to insulin and beta cell resistance. We'll be talking, we'll try to understand in next few slides how this is happening, and this leads to an accelerated lipolysis as well as incretin deficiency and insulin resistance, which leads to all of these problems. So, what actually is metabolic inflexibility? There are certain genetic factors like mitochondrial DNA mutations. If you remember your medicine, mitochondrial DNA, if there is problems with mitochondrial DNA, there is a genetic form of diabetes like maternal diabetes associated with deafness, which is transferred to the fetus, and the child presents as diabetes. So, we understand that mitochondrial DNA definitely plays some part in development of diabetes. Nuclear DNA mutations are also important. If you remember, monogenic diabetes in the form of HNF4 alpha, HNF3 alpha mutations, these are associated with monogenic diabetes. Environmental factors are definitely contributory in form of obesity, malnutrition, and all of these things are related with mitochondrial dysfunction. And once there is a problem with mitochondria, there is both beta cell dysfunction as well as insulin resistance. And once both of these processes start, this leads to development of type 2 diabetes. So, if we remember our biochemistry classes, mitochondria has three main functions: A, ATP generation; B, reactive oxygen species production, as well as apoptosis. If you remember, once glucose enters the cell, it enters the glycolysis pathway and it generates pyruvate, and this pyruvate then enters the TCA cycle and produces NAD and FADH2, which through electron transport chain helps in the production of ATP. Some of these electrons, because of some problems, some of these electrons are not utilized, and this leads to development of reactive oxygen species. When this difference is more, then the mitochondria is not able to function properly, and this leads to activation of caspase C and cytochrome C, which leads to apoptosis of that cell. So, all of these processes are important for a normal cellular function. But it is not only pyruvate that helps in generating this. If you remember, beta oxidation of fats also occurs in the mitochondria, and it is through acetyl coenzyme A, anaerobic respiration occurs and beta oxidation of fat occurs, and there is increased production of reactive oxygen species then. So, mitochondrial inflexibility actually refers to dysregulated energy substrate metabolism in the mitochondria. In a healthy mitochondria, the mitochondria can switch from glucose using pyruvate to fatty acids. But when there is excess glucose, this leads to development of glucose toxicity in the mitochondria, and such mitochondria are not able to switch to do this switch, and this leads to mitochondrial dysfunction. This is what I was talking about. Mitochondria are not able to fully utilize the nutrient substrate, so there is the fuel availability is reduced, and there is a net mitochondrial oxidative activity, and because of this there is development of complications. If you remember how complications develop in diabetes, we always talk about oxidative species, and this is where the problem is, because the mitochondria are not able to switch themselves. And if we talk about at the level of muscles, again during the fed states, carbohydrates are used, and in the fasting state there is lipid oxidation. But this inability to suppress lipid oxidation and switch to carbohydrate oxidation in response to meals or insulin stimulation is called as metabolic inflexibility, and this is the reason why your patient develops insulin resistance, why your patient starts generating more amount of reactive oxygen species, why your patient starts developing complications associated with diabetes. So, in patients with type 2 diabetes, there is 35% reduction in mitochondrial respiration. this leads to reduced skeletal muscle mitochondrial oxidative capacity, and this leads to reduction in skeletal muscle mitochondrial content. And we know that mitochondria are the energy sources of the cells, and once there is reduction in the mitochondrial content, the energy production of the cell is not appropriate, and this leads to apoptosis of that cell. So, in obese type 2 diabetes patient, there are changes in the cell, like I was telling you, glucose is not utilized, and fatty acid oxidation pathway is the predominant pathway. So, what happens once mitochondria switches towards fatty acids? There is increased fatty acid oxidation, which leads to increased beta oxidation and increased fat in the subcutaneous tissue, and this is what is responsible for insulin resistance. And all of these things actually then translate into increased glucotoxicity and mitochondrial dysfunction. What happens at the level of insulin signaling? We know that once there is increased glucose, it increases insulin secretion. Normally what happens is, once insulin binds to its receptor, the IRS1 or the insulin related substrate 1 is phosphorylated, and this phosphorylation actually leads to phosphorylation of GLUT4 receptors, and this leads to translocation of GLUT4 receptors in the membrane, and these GLUT4 receptors actually helps in taking these glucose molecules into the cell. But once there is mitochondrial dysfunction, this process cannot occur, and these IRS1 molecules then progress through the MAP kinase pathway, and this is associated with increased inflammation, cell proliferation and atherosclerosis. So, this is what happens. Even insulin is there, this phosphorylation is not occurring, and this is what is insulin resistance at the molecular level. So, there is an alternative hypothesis that mitochondrial dysfunction accounts for both skeletal muscle, like I told you, insulin resistance, as well as impaired pancreatic cell insulin secretion. So, we are proposing a unified hypothesis. We are saying that it is a mitochondrial dysfunction that is responsible both for insulin resistance as well as reduction of insulin secretion, and this is what we always have been trying to achieve. We have talked about different pathophysiologies for development of diabetes, but the basic cellular changes that are occurring are at the level of mitochondria, and this is happening because long term exposure of glucose free fatty acids actually surpasses the adaptive threshold, and this leads to lipotoxicity and glucotoxicity, which leads to reduction in ATP generation and cell apoptosis. If you remember, your patients with diabetes, with poorly controlled diabetes, always come to you that they are feeling fatigued, they are feeling weak, and this is because they are not able to produce enough ATP because of the glucotoxicity and the lipotoxicity. So, what actually the mitochondrial dysfunction do to the organ system? It leads to reduction in ATP synthesis, reduction in mitochondrial density, which leads to changes in the electron transport chain, and this leads to gluco and lipotoxicity. All of these leads to reduction in ATP synthesis, and this leads to reduction in antioxidants enzyme, decreased mitochondrial numbers, and it is the antioxidant enzymes which saves a patient from diabetic complications, and this is how patients develop complications associated with diabetes. So, even after improving glucose control, this dysfunction was not improved, and this is why even in the trials like UKPDS, you saw that there was some number of patients who did develop complications. So, we were trying to make drugs that are able to modulate this. So, mitochondrial modulators are drugs that benefit patients by these novel mechanisms that would make the system, tissue or organ function efficiently without altering the hemodynamics, and we are still trying to find these. What actually these modulators do is they correct this metabolic dysfunction which occurs because of inappropriate or underutilization of carbohydrate and overutilization of lipid substrate. These directly correct the metabolism defects at the level of liver. So we are trying to address the core pathophysiology of diabetes, and in contrast to SGLT2 inhibitors, metabolic modulators directly improve energy efficiency or expenditure. We know that SGLT2 inhibitors actually reduce the total amount of substrate available by helping them pass through urine. I'll just take 1 minute or so. So what will be an ideal OAD for managing diabetes? It will be a OAD which is able to target this mitochondrial dysfunction, which is able to target insulin resistance and insulin secretion, and this will help in improving mitochondrial biogenesis. It will improve insulin sensitivity, it will improve beta cell function, and the final effects will be reduction in HbA1c, reduction in blood pressure, reduction in CV disease, and it is weight neutral. So thank you from my side. Pioglitazone has been proposed to be one of the drugs that actually modulates mitochondria. The views have been different in different studies. The research is still going on that. Some studies suggest that actually pioglitazone increases mitochondrial biogenesis, but other studies refuted it. Another molecule which was looked into this was alpha lipoic acid, which we use for diabetic neuropathy. Authors did try to look it as a molecule which will modulate the mitochondria, but still we are trying to understand its effects. Thank you.
Thank you, Dr. Atul, for the beautiful explanation of the mitochondrial modulation, which is the basis of diabetes pathogenesis, the metabolic inflexibility and genetic factors, and the obesity leads to mitochondrial dysfunction and oxidative stress, and leading to beta cell damage and ultimately diabetes. This novel mechanism is still under research for the therapeutics. Thank you.
Thank you. Thank you, sir.